안녕하십니까, 이존치과의 손영희입니다.
Greetings, I'm Dr. Son Young-hee of Egood Dental Clinic. Today I want to talk about anatomy and physiology of maxillary sinus. In talking about placing implants in the maxillary posterior area, maxilla is 3.5 times more edentulous than the mandible. Strong occlusal force is applied more than anything else. Compared with the lower bone, the upper bone has less bone density. Pneumatization continues to occur throughout the course of our life, and the volume decreases. The residual bone decreases. Compared with the lower, the success rate of placing implants in the upper posterior area falls short. Because of pneumatization, when there is a lack of residual bone, additional procedures may be necessary. Let's take a closer look at sinus surgery. Sinus is a type of paranasal sinus. Paranasal sinus include maxillary sinus, frontal sinus, ethmoid sinus, sphenoid sinuses. And maxillary sinus is the largest paranasal sinus, and all sinuses are lined by respiratory epithelium. Today we're going to talk about maxillary sinus. Let's look at the characteristics of the sinus. Throughout the course of our life, pneumatization continues to occur. Pneumatization accelerates after extraction or loss of tooth. Through pneumatization, the size of the sinus increases. At times, we can come across sinus with a very thin bone lining. Let's take a look at the anatomical aspect. I've mentioned that among the paranasal sinus, the maxillary sinus is the biggest. Its volume is around 12 to 15 cc. On average, if you look at the dimension, the height is 33 millimeters, width is 23 millimeters, and length is 34 millimeters. And it has additional structures like ridge and septa. If you take a closer look at the maxillary sinus, the roof is orbital floor, base, lateral nasal wall, floor, the maxilla, apex, the zygomatic process. It has quadrangular pyramid type of form. If you look at the maxillary sinus wall, there is lateral wall, medial wall, anterior wall, posterior wall, superior wall, and inferior wall. They're all important, and I want to talk about certain walls more specifically. When we do lateral approach, we come across lateral wall. The characteristics of the lateral wall is that there's very steep difference in terms of thickness. It can be very thin or it can be very thick. In other words, when doing lateral approach, if we are to do window prep, this determines the difficulty of lateral approach. We need to assess the thickness of lateral wall via CT ahead. Next, I want to talk about the medial wall of maxillary sinus. The notable structure here is maxillary ostium. This has about 3 to 5 millimeters of bony diameter, and the functional opening is about 2.4 millimeters. The position is in the upper middle area of the maxillary sinus. It is about 4 centimeters from the inferior wall and 2 centimeters from the anterior and posterior wall. So it's positioned in the middle area. Next is inferior wall of maxillary sinus. This is also referred to as sinus floor. This is lower than the nasal floor. It is about 10 to 12.5 millimeters lower than the nasal floor. The important thing about the sinus inferior wall is that we need to be aware of these forms. If it is irregular, it can be very difficult to detach the sinus membrane. If it is smooth, then we can very easily detach the sinus membrane. If you look at the journal, it talks about correlation between sinus wall and teeth. Based on the correlation between the inferior wall and teeth, we can indirectly anticipate the irregularity of the inferior wall of the sinus. There can be 4 different positional relationships. First, the root and sinus are separate. Second, the root is in contact with the sinus floor, however, there is no projection. Third, the root is projecting laterally along the sinus cavity but is outside the sinus borders. Fourth, the root is projecting into the sinus cavity. We can largely divide it into these 4 types. As shown here, the root is projected inside the sinus, and even after extraction, we can come across irregular sinus floor. Let's look at the second positional relations. We need to understand where the lowest point of the maxillary sinus floor is. As shown, the lowest point of the maxillary sinus can be located on the buccal side. Here it is in the middle, and here it's on the palatal side. If the lowest part of the sinus floor is located on the palatal side, it can be extremely difficult to detach sinus membrane. However, fortunately, in most cases, the lowest point of the maxillary sinus floor is either located on the buccal side or in the middle. The lowest point of the sinus floor located on the palatal side is extremely rare. Next is a maxillary sinus inferior wall. This affects the shape of the sinus floor, and there is a septa dividing the sinus. Septa is most frequently observed between the second premolar and first molar region. The incidence rate is about 31.7%. The clinical implication of sinus septa is that it becomes more difficult in doing sinus membrane elevation. This is a structure that makes it more difficult. It is known that the apices in the second molar are the closest to the sinus. To talk about septum briefly in the inferior wall of the sinus floor, you can see the septum in the CT. It can be divided into 3. There's underwood septa, partial perpendicular septa, and partial horizontal septa. Let's look at Underwood septa. It was first reported by Arthur Underwood. Underwood septa are osseous ridges delimiting the root compartments of the premolars and molars. They're encountered in 31% to 48% of cases. They appear to develop in 1 or 2 ways. The incidence rate is known to be between 31% and 48%. The septum incidence rate is most prominent in the premolar region, with the percentage being 73.3%, and septum exists in buccal-palatal direction. Underwood septa can be divided into 2. There is a primary septum and secondary septum. Primary septum refers to what was already existing. Secondary septum refers to a septa that is a result of irregular pneumatization of the sinus following loss of maxillary posterior teeth. As shown on the research, septa exists primarily around premolar region. If you look at the average height, it is about 3.5 millimeters. Next is partial perpendicular septa. This septa exists immediately posterior to the maxillary sinus ostium. When partial perpendicular septa develops in the maxillary sinus, it can divide the sinus into two incomplete compartments. Next is partial horizontal septa. The partial horizontal septa does not exist in sinus floor and does not make sinus surgery more difficult. This septum is a horizontally located maxillary process arising from the palatine bone and the inferior concha. In the case of partial horizontal septa, the precautions we need to take is that after sinus surgery, because of this, drainage may not occur properly, and as a result, problems may occur. This is the clinical implication that we need to be aware about. It is difficult to call this a septum, but there can be complications related to complete septation. By complete septation, it refers to a situation where sinus is completely divided into two, and the bigger part is referred to as the sinus and smaller part as accessory sinus. When a single sinus is divided into two compartments, we refer to this as complete septation. Sinus septum is a structure that causes immense difficulty. If there's sinus septum, when we do prep to form window, we need to make sure that window is formed so that sinus septa is not invaded. It can be kind of difficult in that regard when we do sinus membrane elevation. There can be many associated challenges. We can call sinus septum an anatomical structure that makes sinus surgery more difficult. Septum also causes various difficulties when doing lateral approach or window approach. But from a different perspective, if we can address septum appropriately and safely elevate the membrane because of the characteristics of the septum, we'd be able to get better osteogenesis. We'd be able to utilize more bony surface. Septum causes incomplete compartment. Therefore, when containing graft material, we can do it in a more stable manner. Also, when placing implant accurately on the septum, then it can be of help gaining more primary stability. There can be positive aspects as well. When there's no septum, graft materials will be maintained in this way. However, if there is septum, graft materials can be positioned here. It has more bony contact for osteogenesis. In terms of bone regeneration, it can have more positive effect. We've talked about the anatomy of sinus. Next, let's look at the blood supply of sinus. The primary blood supply of maxillary sinus comes from posterior superior alveolar artery, followed by infraorbital artery, greater palatine artery, and sphenopalatine artery. These arteries are in charge of blood supply for sinus. I'm sure you've heard of it in other lectures, but what is very important in arterial blood supply to sinus is that there is anastomosis between posterior superior alveolar artery and infraorbital artery. There's extraosseous and intraosseous anastomosis around the sinus. This is something that everybody knows. The arterial blood supply structure includes intraosseous and extraosseous anastomosis. Literature reported by Sola is frequently referenced. Extraosseous and intraosseous branch surrounds the sinus. As shown, Once transillumination is done as shown, you can see intraosseous anastomosis artery. Intraosseous anastomosis is very important compared with extraosseous anastomosis. This is because when we make incision and elevate the flap, the extraosseous anastomosis exists on the flap. So there's very little possibility of us coming across the extraosseous anastomosis artery. Unless you make too deep vertical releasing incision, it's difficult to damage this artery, so it's relatively less important. However, in the case of intraosseous anastomosis artery, when we prep a window, if within the window design, if intraosseous anastomosis artery is included, then more bleeding can occur. If you look at the size of the intraosseous anastomosis artery, it is in general 1.3 millimeters, give or take 0.5 millimeters. It is rare, but at times the size can increase up to 3 millimeters. It can be of significant size as shown. The artery size is important because if the size is big, then if there is damage, the amount of bleeding will increase. Intraosseous anastomosis artery can run in different patterns, but in general, it runs like a bony canal form, or it shows a groove-like form as well. Where is intraosseous anastomosis artery? There's a lot of variations, but on average, it is 19 millimeters superior to the edentulous molar area. And extraosseous anastomosis artery is 2 millimeters more superior. The location of intraosseous anastomosis, it can show straight line, U-shape, or down step line. What is fortunate is that in most cases, about 75% of the time, it shows straight line. When it is U-shape or down step line, it will be very difficult to form window. However, in most cases, it is straight line and we'll be able to form window in a safe manner. In the case of U-shaped line, which accounts for 21.9%, and downstep line, which account for 3.1%, when we do lateral approach and plan for sinus graft, we need to pay attention so that minimal damage to the intraosseous anastomosis artery can be made. As shown, there's bony groove and bony canal. Intraosseous anastomosis artery are as shown. As mentioned, there's higher possibility of us coming across the bony groove type rather than the bony canal type. There's bony groove here, and it can be in the form of canal like here. If you look at the research published by Nicholas Elian on CT, we can detect intraosseous anastomosis artery. Through CT, we can find intraosseous anastomosis artery about 50 or 52.9% of the time. So half the time we will not be able to detect it even on CT. Let's talk about clinical implication of intraosseous anastomosis artery. In order to do sinus grafting when forming window, we need to avoid intraosseous anastomosis artery. That is how we should design the sinus window. This is the clinical implication that we need to consider. Next is venous drainage of maxillary sinus. Major drainage include anterior facial drain and pterygoid plexus, and minor drainage include sphenopalatine vein. Now let's look at nerve innervation of maxillary sinus. As we all know, sinus membrane and maxillary sinus nerve innervation is dominated by posterior superior alveolar nerve. We looked briefly at the anatomics, and now let's move on to physiological aspect. What kind of function does maxillary sinus serve? There is still controversy and not much is known. As shown, it serves potentially these functions. If you look at these functions, clinically speaking, sinus is in charge of drainage and ventilation. Simply put, we can summarize like that. Let's look at sinus membrane. Another name for it is a Schneiderian membrane. There is continuity with nasal mucosa. However, it does not have elastic fiber. So, because it doesn't have it, it can be detached easily. If sinus membrane had been similar to nasal mucosa, it would have been extremely difficult to detach. If you look at the physiological characteristic of Schneiderian membrane, there's a mucous blanket. There's two layers. There's a sole layer and gel layer. There's a sole layer below, and on top there's gel layer. The different characteristics of gel layer and sole layer vary. The outer layer is gel layer. It is like mucus and is more sticky. Below there is sole layer, and it's more serous. In the case of sole layer, it helps ciliary movement, and through osteotome, it allows easier excretion. It serves as a lubricant. The gel layer collects the bacteria and other debris and send it to the osteum through ciliary movement. The gel layer collects bacteria and debris very well. There's two layers, sole layer and gel layer, and after that, the bacteria and debris that was collected by gel layer is transferred to osteum via ciliary movement. They are all transferred towards the osteum through ciliary movement. There's about 1,000 strokes per second, and the speed is about 6 millimeters per minute. Ciliary movement is done to excrete these substances out. This is referred to as mucociliary clearance. Through ciliary movement, the different debris and bacteria are all excreted outside. This is an immune system. Mucociliary clearance allows for sinus to be aseptic in most cases. Excretion is done from ostium to middle nasal meatus to nose to nasopharynx. Mucociliary clearance is very important for the health of sinus. All endpoint of the clearance within paranasal sinus head towards the maxillary ostium. Ostium's patency serves a very important role in sinus health. If there's patency in ostium, there's no major problems in most cases, but once the patency is lost, problems occur. As shown, ostium is blocked. Then, sinus membrane will be thickened. Inflammation will occur. Let's look at microbiology of maxillary sinus. 80% of the time, it's bacteria-free, it's aseptic. But there can be aerobes as well. The problems are mostly caused by anaerobes. Anaerobes cause pathology within sinus. We've looked at the anatomics and physiology of sinus briefly. If you're interested in more details, please refer to offline master course, and I hope to see you there. Thank you for watching.